And I'm very happy to introduce to you Professor Frédéric Amant. Is a professor at the Leuven in Belgium and also University of Amsterdam in the Netherlands. In Amsterdam, he heads the Department of Gynaecological Oncology of the University Medical Centers. So very welcome to you.
Thank you for the introduction. Thank you very much for the invitation. And I want to thank Michael already for introducing me during his lecture. And it's great that you bring both of us on the floor here, because partner in crime regarding the Cancer in Pregnancy project. So from the first days on a conference like this, we met and we decided to merge forces. That was mainly on cancer in pregnancy. The lecture of today is actually one step before. Fertility preservation, which is in fact much more common than cancer during pregnancy. And I was asked to maybe not speak the 30 minutes, but maybe in a reduced way, allowing you to
Thank you.
Ask questions. We will see, allowing you to
Thank you.
Ask questions. We will see if we manage there. Does this work? No. Okay. So, what is the take-home message? I want to show you that fertility preservation is in fact frequently possible, and especially in early stage gynecological cancers. I want to show that for these patients it is best to refer patients to an oncofertility clinic with a protocol. And the reason is that actually in many cases we have to deviate from standard treatment. This referral is important. And I want to introduce you to a very new project, which is the Advisory Board on Cancer, Infertility and Pregnancy under the umbrella of the INSIP. This is the agenda. We will kick off with introducing you to the importance of the oncofertility. We need a dedicated team that is experienced with the topic, and we have to tell our patients, counsel our patients, that we can try to preserve fertility, but that's no guarantee yet that we will be able to be successful. And that we in fact don't have randomized studies. If you look to all the lectures, that we in fact don't have randomized studies. If you look to all the lectures here or changes in clinical practice, all changes in clinical practice in medicine are based on randomized studies. This is the level 1 evidence. Well, in this setting, also what Michael said in the cancer in pregnancy field, there is no level 1 evidence. It is cancer in pregnancy field. There is no level 1 evidence. It is always observational studies. So we have to discuss that with the patients. And we should look very careful to our patients. Who is sitting before you? Who is asking to preserve fertility? How strong is the desire to preserve the fertility? How strong is the desire to preserve the fertility? How meaningful is it to preserve fertility in a 45-year-old woman, 47-year? These are the questions that we receive. Someone is 41, she does not have any partner any time, but she wants to preserve fertility. I mean, how realistic is it that, but she wants to preserve fertility? I mean, how realistic is it that preserving fertility will at the end in a pregnancy? And what about proven fertility or infertility? So these are all concerns we need to take into consideration, and we need a dedicated team to deal with that. More in general, maybe not always for the gynecological cancers, but in general, there are ways to preserve fertility and to store gametes. We can, there are different ways, but at the end, we want to store either ovarian, a partner that is aimed to be also the father of the child. We can also cryopreserve the embryo. And as you can see, there are different ways to obtain this. But that is very crucial. We need a structure that is able to do all these techniques at the end of the day to an autotransplantation, fertilization of the oocyte for an embryo, and then to replace it either in the patient herself or in a surrogate. The reason why this Cryopreservation is so important and actually also so difficult. Preservation is so important and actually also so difficult in women because it's much more challenging in women to cryopreserve fertility than in men. So also their nature is not really very fair, let's say it like that. And the reason why it is much more difficult for women than for men is pictured here. What we see here is an oocyte with sperms around. And what is clear is the volume. An oocyte is really a huge cell in contrast to the sperms. But this cell is mainly filled with water. If you would cryopreserve, you freeze this cell, water will expand and the membrane, in fact, will rupture. And that is the difficulty of fertility preservation in women. In men, you can easily store cryopreserved sperms and you defreeze. And that is the reason, just an anatomical reason, basically. So we need actually, both for men and women, like facilities to do that. And at the left, you see a patient that we operated and we took some ovarian tissue, so it is immediately cryopreserved. This is in ovarian tissue, so it is immediately cryopreserved. This is in the theater, in the surgery room. You see a container, and that container is brought then to the lab where this tissue is stored. And this is like a container at minus 180, that all these tissues are stored. So just to give you an example. All these tissues are stored. So just to give you an example. So you see that we have a lot of infrastructure, we do a lot of efforts, but here I want to share with you that we actually have to better select our patients. And this is a real-life experience in the hospital of Leuven. And to make a long story short, we cryopreserved tissue in 66 women, that was with breast cancer. And then there are several reasons why, at the end of the day, out of these 66, only one patient, we transplanted the ovary. So in 65, we did do all the efforts. We paid for it, all the administration was done. But in fact, for the majority, it was not, we did not use it. So we better have to select patients to do all these efforts. So I think that is important for the clinic. This is a model of care that is presented and that also shows that, in fact, we need to have like a structure in place when a patient arrives. And that, and in the green, we see this is the traditional clinical path. And then the patient, in fact, is young, and she says, I want you to do everything what you can to preserve my fertility. And then there is like a fertility preservation counseling, where we decide to estimate, to inform the patient, to see how realistic is this. So we need to talk to the patient, to assess the patient. We have to propose actually all the options we have, discuss this with the patient, and maybe help her to make a decision. And if we then agree that we will do this, then, well, we try to preserve fertility. And that goes in between diagnosis proposal, and then, in fact, the patient goes back to the clinical care team. We hope she will survive and that she will be able to use the material, that cryopreserved material, and then later on we will try to use the material and to try to facilitate conception. But you see here that this is now just one slide, but there's a lot of things, a lot of people that are involved. You need a protocol. And if we really want to help our patients, we have to set this protocol up, this whole infrastructure, and then we are ready to treat our patients in a standard way following the protocol. Gynaecological cancers in particular. One of the ways we can spare or when fertility is at risk if we have to irradiate the pelvis. Sometimes this is for colon cancer, it is for cervical cancer, we have to do that, but the ovaries are really the fertility is gone. So one of the things we do is that we transpose the ovaries, so this is the uterus, we we cut the ovary or the tube here, and we transpose. So this is the vascular bundle, and we fix actually the ovaries upper flanks of the body. So that means that here we can irradiate, and the ovaries remain far from the field of irradiation, and they remain active. But we have to tell so the advantage is it's surgery. You can plan it actually the next day. The patient can go home the next day. Surgery, you can plan it actually the next day. The patient can go home the next day. But there is and then we can irradiate. But there is one thing we definitely have to tell the patients. You see this angle here. So this is the vascularization of the ovary. If this angle is too narrow, this is the vascularization of the ovary. If this angle is too narrow, there's no blood flow anymore. So then the ovary will become necrotic. It will not function anymore. So it depends a bit on the institution, on the surgeon. But then there are series that in 1 in 2, in some hospitals, in 1 in 2, the ovary does not function. So we have to tell the patient what is your experience, that we can tell the patient that success is no guarantee. Also, it is important to tell the patient at that stage that this happened. When we started doing this procedure quite a while ago, we had patients who came to the emergency unit with gallbladder symptoms. So she was referred to internal medicine for cholecystitis. But what in fact happened is she had just an ovarian cyst. But due to the fact that the ovary was not deep in the pelvis, but just under the gallbladder, it looked as if she had like a cholecystitis. And then suddenly she was referred to us, and we could actually explain to the patient that we could be conservative. So that is a consequence also of this kind of surgery. Then one of the most common things is cervical cancer. And in fact, of course, as you know, there are different stages of cervical cancer. And actually, a common situation is stage 1A1. So that means there is a cancer, but it's only growing 3 millimeter maximum. So it's really the beginning of cervical cancer. And what we there do is actually, and this is what you see here. This is the vagina, this is the cervix, and this is the isthmus of the uterus. And this is then the view, actually, if you look in speculo, and what you basically do is the conization. You remove actually the part where the cancer is, and this is what you remove. And actually, for this early stage, this is sufficient. Also in standard practice, we do this. Even if a patient does not want to preserve her fertility, that is the standard treatment for the earliest stage of cervical cancer. So this is the conization. And this will actually allow fertilization, a normal pregnancy. And the reason why I say this here also relates to the next slide. You see here that we remove this part, but a large part remains there. You see here, this is basically the same, and also this part remains. And that part is important because continent part, or makes the uterus continent for a fetus inside. So that means if we don't touch these tissues, a pregnancy will be able to develop normally. However, if you go one stage further, so for a larger cancer, we do a trachelectomy. This is the uterus, and as you see here, the cervix is here. This is part of the vagina, and also part of the parametria, so the supporting tissues are removed. And then this is removed, so this is a large part of the uterus, of the cervix, and upper part of the cervix is removed, and then of the uterus, of the cervix, and upper part of the cervix is removed, and then the remaining part of the uterus is sutured on the vagina. But then you understand that this supportive tissue, this continent function of the cervix is removed. So technically it's possible of the cervix is removed. So technically it's possible, but I'm a bit worried about the outcome of pregnancies. And this worry is not really a worry, it's a reality that these pregnancies in fact are not so easy and always or frequently have a preterm delivery. And these are data from Denmark, where they did do a vaginal radical trachelectomy. So the picture I showed is the abdominal way. You can also do it from below. And these are the data from their center. You see that actually 55% of the patients needed to be referred to fertility treatment. Because indeed, this cervix has a function. The sperms have to cross the mucus and the cervix in a normal physiological way. But now you remove this. So fertility, the conception is actually much more difficult. And 1 in 4, in fact, so that's one step you have to take. But then, if you become pregnant, you see that only 37% in fact had an at-term delivery. So many preterm deliveries. And Michael showed you in the previous session, preterm delivery is associated with actually a worse cognitive outcome. That's why, personally, I'm not in favor of this radical trachelectomy. Because I also believe there is a solution for that. And my belief is that the use of neoadjuvant chemotherapy could help us here. What is the idea? The idea, if you have a tumor, that you give chemotherapy, you shrink the tumor. So that means that the radicality of your surgery should not be so radical. So then you maybe can do only this conization. And then you leave actually this important tissue of the cervix and the isthmus, you leave it there, and the tissue of the cervix and the isthmus, you leave it there, and the uterus can retain its function. And what this slide shows, if you do a cone resection, you see here the prematurity rate is 15%. You see here the prematurity rate is 15%. If you do this radical trachelectomies, it goes up to 50 and 57%, so it's really quite high. And if you then compare this with the use of neoadjuvant chemotherapy and then afterwards, so a cone, look, you have the same figures. So the theoretical concept fits. By using chemotherapy, you can reduce a tumor, less radical surgery, and you keep these important structures of the uterus. There is a reason why this is, if you look to the literature, there is much more data or practice on trachelectomy. And the reason is also to some extent the fact that there are no prospective studies. We have only case series of larger institutions. And that's why we decided to set up a study. In fact, there were 2 initiatives in the world. There was the trial by Marie Plante, and there was the NEOCOM-F study from our group in the Netherlands. So we also thought it would be not so logic to split forces, so we decided to merge and to make there one trial. And so we decided to do this Contessa NEOCOM that is well published and is now ongoing. So we need like 92 patients, and 9 patients are included already. So the idea is that we select our patients, we give the chemotherapy, and then we hope that this works very well. And part of the study is also that maybe we have we really want good figures of a prospective study. Also the need to irradiate, but sometimes your surgery is not so adequate, so then you have to irradiate, but then you lose your fertility as well. So you really take all important clinical considerations or things into consideration, and then we hope that at the end of the day, this method that I think should be in favor, that we can really document it and share it, and then I hope it will be executed more in clinical practice. That was about cervical cancer, and now let's go to ovarian cancer. This is still on borderline cancer, so borderline, it's a precursor of the invasive, or maybe sometimes it's a benign. There we know that actually it is safe to remove the borderline tumor and to keep the uterus and the other ovary. But we have to take into consideration that if you do a cystectomy only, so 6 times higher that you have a recurrence, and then you have to reoperate, but the survival is the same. So the only risk here is that if you do a cystectomy, you risk a relapse of the borderline, but not of cancer. So that you have to tell the patient. If you remove the ovary and you keep one ovary, you don't have like this higher chance of ovarian cancer. Well, also invasive ovarian cancer, if it is stage 1, there is a way to preserve the fertility. This is now actually the only study that basically looked to the survival data, or it's a review that summarized everything, and you see this box is really in the middle of everything, and you see this box is really in the middle also here. That means that the overall survival and the disease-free survival of all these papers suggest that it is safe. So there are no difference in terms of overall survival or disease-free survival. But is really only limited to stage 1. We do not recommend it for higher. Really only limited to stage 1. We do not recommend it for higher stages, even if there is a small peritoneal lesion or the uterus is involved. Then we do not recommend fertility-preserving surgery for ovarian cancers. And of course, we know that the disease can recur. But what these data actually show is, that the fact that you keep the ovary, the other ovary, and you keep the uterus, it does not increase the chance that the disease will recur. But of course, every ovarian cancer has a chance that it will recur, also in this population. But that is mainly related to the aggressiveness of the tumor, to the tumor biology, and not to the fact that you keep the uterus and that you keep the other ovary. So that's something we have to explain to the patient. And what we then do is that we remove the ovary, and we remove lymph nodes, we explore the whole abdominal cavity, we remove the omentum, we take peritoneal biopsy, or that it is stage 1. We tell the patient, we believe you can retain your fertility, and you have a chance of recurrence, but this chance is the same as if we would remove the uterus and the other ovary as well. That's how we deal with it in clinical practice. Also, sometimes we need to give chemo. It remains actually intact with the chemotherapy that we use there. That was on epithelial ovarian cancer, especially in young women. There is a type of ovarian cancer that only occurs in women younger than 30 years, and that are germ cell tumors. And these tumors have one characteristic. So I just said for epithelial ovarian cancer only for stage 1, but the germlines, if it's there is peritoneal disease, they are so chemosensitive that even in that case you can preserve fertility. That's an exception we have to make. Then in endometrial cancer, the numbers of endometrial cancer are increasing. It's about 3-4% of women actually have who are under 45 who have endometrial cancer. There we can have an option. That means that for atypical hyperplasia, so this is the That means that for atypical hyperplasia, so this is the precursor of endometrial cancer, or grade 1 endometrial cancer, we can preserve fertility. But we need a pathologist who looks into it, because we really have to sure about the cancer, and really a curettage to be able to examine everything. And then we need an MRI or an expert ultrasound, because it is only safe if there is no growth into the muscle of the uterus itself. So it needs to be really a superficial cancer. And what we do then is we give hormone. The organ that will become pregnant itself is involved, so there is no place for surgery. Also, if you give radiotherapy, this is not compatible with a normal pregnancy. So the only thing we can do is give drugs. The advantage of these grade 1 endometrial tumors, they are hormone sensitive. So they either have the estrogen receptor or the progesterone receptor, and then we give high dose progestins, and then we assess the response with DNC at 6 months. If actually at 6 months there is no response, probably the tumor is not sensitive to hormones. At 6 months there is no response, probably the tumor is not sensitive to hormones, and probably we cannot preserve the fertility. And of course, then we need the patient, but does she have a partner? Does she want to conceive now or maybe later on? So in the best case, she should conceive immediately, but sometimes you have to continue the hormonal treatment until she has found the right man to be the father of her children. Last part, it's actually very new, novel. This is the advisory board on cancer, infertility, and pregnancy. And in 2 weeks' time, Lancet Oncology will publish a comment on this. The idea basically, or it's as Michael actually already introduced, a lot of data from the INSIP actually show that cancer can be treated during pregnancy. The fertility part is less prominent presence, but still it is there. And I felt the need to improve our service to patients. I received many mails, telephone calls from doctors. Okay, and then I give my best advice, but I'm not an expert in everything. So there were definitely cases where I said, okay, you have to talk to this person or maybe ask that opinion, for example, for a hematological cancer or really something on radiotherapy. I'm not a radiation oncologist. So one person cannot cover all fields. So we decided to look for a new model. And this is then the advisory board, which is then an online tool. I will show that later on, but how it basically works is that if there's a patient in the world, talks to the physician, and then he or she can consult our online tool, and so a specific case, we have some, or we are building on national groups, and actually with experience gained in the INSIP, it will go back actually to the treating physician. Sometimes maybe the national group or the regional group does not know the answer, and in many cases, because we are still growing, we don't have this national group yet. Then we have this overarching international group that actually can be consulted for this particular case. This is actually how it looks. You see already the logo. Huh? This is the baby, the cancer, the mother, and this figures actually all the experts who are looking to the mother and trying to provide their advice for this particular case. If you now take your computer and you go to the EPSIP website, this is what you will see. And your physician can ask an advice without inlogging, without a password, and it's free of charge. So you just log in, and this is actually what follows there. If you say, I'm a patient, the site will say, your physician has to complete the file, not the patient. And then there are several pages that has to be completed, but it's really minimal information. So the threshold to complete this is quite low. And then at the end of the day, now I go to what we as physicians from the EPSIP see. These are the several cases, so it is anonymous. And here you see, okay, there was a new case, so this is my advice. This is Lone Storgaard from Denmark, who provides her advice, and this is a Belgian doctor who gives her advice as well. And this actually, the advantage here is that all the experts already see what someone else has written. So you can say, I agree with that, but I want to add this. So you don't have to repeat everything. Now, there are similar initiatives in the world, very few, but they work with an online, not an online, an email-based process. I see there was someone from Olijf here. So in the Netherlands, we have the AKZ, which is the advisory, which is the Dutch advisory board, but that works mainly by email. So we already receive so many emails. So this is, the burden of emails is actually already too high, and I think this is more flexible, and that you better have an overview of what others have added. So all these advices I try to provide within 4 to 7 days. We try to provide to make this letter and to send this letter back to the physician, who then has to talk to the patient and say, this is what these group of experts say. So I think this is, to me, this was a way to how we could transfer the experience. We have been constructing guidelines as well, but we also feel that it does not always, or physicians are not aware of it, or they have a difficulty in seeing where does my patient fit in this guideline. So they need this kind of personalized information. So I want to conclude, and I hope I could show you that fertility preservation is frequently possible, and especially in the early stage, but that we really have like a adequate setting in place to be able to provide best care, because you always deviate from standard treatment, and the standard treatment is the best treatment. So you should have a good argument. You always deviate from standard treatment, and the standard treatment is the best treatment. So you should have a good argument to deviate from the standard treatment. So we need also, to deal with that, we also need a motivated patient, and especially if you have assisted reproductive techniques, you need the group experts in place to do that. And I hope you are, and as group experts in place to do that. And I hope you are as enthusiastic as I am about this EBSEP. And this is my concluding slide. Thank you for your attention.
Thank you very much. Thank you very much for this lecture about how fertility can be preserved during cancer. I think it is very positive to hear all the efforts which are being doing. So thank you very much. I don't know if there's any questions I can see. Do we know if there's any questions I can see? Do we have some only short questions, because I have already capitalized on your lunch, ladies. So only short questions if you have the time. Professor, do you have time for some short questions? Okay.
Is it open? Okay. Is there a limit on how much time or how many tries she has? Because the hormone stimulation can be a danger for the woman's health.
So the question is if the patient is cured afterwards. That's a very good question and very relevant question. We try, during a recurrence, a patient becomes pregnant. Because a recurrence it's a poor prognostic sign. So we try overall to wait for 2 years. And after 2 years, we think that the most aggressive cancers will recur. So after 2 years, the prognosis improves. It's more likely that the patient is really cured, and then we give the green light to conceive. But that is never 100%. I think.
Okay, but for example, for endometrial cancer, the guidelines say that you have to start immediately after you are cleared. So
well, only if there's a partner available.
You are cleared. So.
Well, only if there's a partner available, of course.
Okay, yes, of course.
But then actually there are no data then to answer your question. I mean, you can only say, well, try to
as fast as possible.
Make a plan. Yeah, don't.
Okay.
Actually, you have to put it like that. I think that women say, yeah, I will postpone my pregnancy, and then maybe you say, well, don't postpone it anymore. Do it now.
Okay.
And I think that's the most realistic way. Yeah.
Okay, and one more question. If the patient succeeds to get pregnant, is she closely monitored during the pregnancy, pregnant woman, or not necessarily?
Actually, what we mainly do is we try to talk to the patient and say, before you try to become pregnant, we will do a staging to make sure that at that moment there is no disease. And when there is no cancer, then we allow them to become pregnant. And I don't think we do then also because maybe there is no really clinical consequence of it. And we try to reassure the patient that, yeah, we don't do this monitoring. And then it's a normal pregnancy, basically.
Okay, thank you very much.
Thank you very much. And I will allow now to end the session. I don't know if you have a question, you maybe could raise it to the professor. Because we have to keep this time schedule. So I don't know if it's okay with you that someone is asking you, and I'm closing the session now. So you're going
fine.
out.
For me it's certainly fine. Yeah. For me it's certainly fine. Yeah. Maybe for the previous, there was another part that I did not answer about IVF. IVF has no impact. We know that IVF does not impair the outcome. We have to realize that IVF does not impair the outcome. We have to realize that IVF, it's a high level of hormones, but it's only a peak. It's very short, and it's too short to have an impact on cancer cells, even estrogen or progesterone positive cancer cells.
I was wondering about the success rate of ovary cryopreservation because I had mine frozen in 2019, and now I'm under hormone therapy for 10 years. And I was planning to receive it back and translate it back into my, after 10 years of hormone therapy.
We
But
talk about breast cancer?
yes. And currently, for example, my ovaries and my uterus is atrophic, and I'm wondering whether it is a possibility for me to gain back my fertility, because
Okay, if I understand it well, I think you would qualify for the positive trial.
sorry?
I think you would qualify for the positive trial. And what does the positive trial says? It is now closed for accrual. Women like you would then hormonal treatment. They are allowed to stop hormone treatment, try to become pregnant,
Yeah.
and then afterwards to well, to continue their hormonal treatment. Actually, I'm not allowed to tell you the results, although I published, they are submitted to an important journal. But there's definitely hope that actually it is likely possible to, or you can, how shall I say, think about it, that for some time you can interrupt the pregnancy and become pregnant. Results likely they will be, because you will follow it then, there is the San Antonio meeting, that is one of the important meetings in breast cancer. That is the first week of December in San Antonio. And the results will be made publicly available. And then you can really see what would be the risk if you... So, but I would first wait these results and then make a plan.
Thank you.
So, yeah. Also, I think you have to talk to your physician because I mean, people like you need to have this 10-year hormonal treatment, but I think you're allowed to ask your physician. And I think there's a general consensus that the most benefit is in the first years. And the longer you give, the benefit or what you will gain from the last 5 years is likely to be quite small. And I think that also, even if the results of the positive trial are not so good, because that's mainly in women that need 5-year hormonal treatment, so even if the results of the positive trial are not so good, because that's mainly in women that need 5-year hormonal treatment, I'm quite confident that 5 years is already quite good, and the added benefit for you for the last 5 years is not so high, and maybe low enough to motivate you to become pregnant. You for the last 5 years is not so high, and maybe low enough to motivate you to become pregnant. Okay.
Okay, so thank you very much for this lecture. And thank you very much. And I have a little problem with our time schedule. I would like us to be back at 1:45. Now there's a time for lunch and for mingling and interacting with the participants here. So thank you very much.